always remember that the whole cardiac, management plus the whole cardiac system, even for step 1 or step 2, is built upon pharmac, right? And pharmac is built upon physiology, right? So we have to understand our physiology as much as we can, right? So the first couple of pages that I need you to refer to is, first thing is 331, okay? So within 331, you should be able to identify all these different arteries and the leads that they're concerned with, okay? We saw how we read a ECG, right? First, as you said, you're going to read the long strip first. Sometimes it's lead 2, sometimes it may be a different lead, okay? Next, what you're going to see is the really big like actual cardiologists and stuff, what they read is AVR, okay? When you see AVR is away from that cardiac vector, right? So AVR is supposed to be always negative, right? So this helps you understand, is the lead placement correct, okay? So whenever you look at AVR, it's to judge, is the lead placement correct? If it's negative, it's good, right? What if there was some depolarization? If you go back and check in the ECG with the 12 lead ECG that we saw in the previous question, you'll see AVR has positive deflection, right? It's because someone had an MI, and now the whole, the electrophysiology of the heart is affected, okay? So in a normal patient with normal, findings, you're going to see AVR being negatively deflected. Does that make sense?
Because of like where the sticker is placed, I guess.
Yeah. Yes. Also, because the lead 2 captures the cardiac vector, electrophysiologic vector of the heart much more accurately, right? AVR is opposite to that. You understand?
Yeah.
Do you know that lead 2 captures the main vector? Have you seen that before? I can show it to you. Do you want to see it?
Okay. So is that why everyone looks at lead 2?
Yes. Yeah.
Okay.
Because so I don't know if you've studied your if you've come across the vectors and all of the lead placements content, but I'm just going to give you a quick thing. All right, this is what I just taught this yesterday, but it's a very helpful diagram to help you understand how the depolarization waves spreads throughout the heart, okay? Now understand that electrical activity only happens, the only communication between the atria and the ventricle in terms of electrical activity is at the AV node, is through the AV node, right? Every bit of the communication is inhibited by a fibrous, a layer that the heart has, right? So the atria and ventricles don't communicate electrically at any other point apart from the AV node, okay? Now, once that signal is received at the AV node, this is the type of deflection it makes, right? You see it goes down. And what does it usually, overlap with is lead 2 over here, okay? The thing is, this is a vector. Vector has a horizontal component. It has some vertical component, right? So you see the components of lead of this main vector you are reflected on lead 1 and even on lead 3, right? And the formula, if they ever ask you anything about it, maybe in a step 1 question, if you add the depolarization of 1 plus 3, it will equal 2. You see the intensity? It's 1 plus 3.
Okay.
Right? That's just vector addition, right? But now you see, as the depolarization of wave is spreading, right? Now the tilt is kind of happening. And again, the reflections on lead 1 and lead 3, right? As you go down, again, the deflection is kind of changing, but now you see that it's going away from, lead 2 a bit, right? And also it's decreasing in intensity. So now it becomes, that dip in the QRS. Okay. Eventually, what ends up happening is the right depolarizes further, and the left faster, and the left takes a little bit of time, leading to a lot of this negative deflection. And finally, the entire thing is depolarized, and you get the nice big QRS wave. Does that make sense?
I think so. Yeah.
Yeah. So that's the importance of lead 1, 2, and 3. Okay. So whenever when you start looking at it, lead 2 is the main lead. If there's a problem in lead 2, you'll know right away that's a problem in the heart, right? So very important to look at lead 2. And as you did, and I'm glad you did it, you have to check 2, 3 AVF at one go. Why? Because this is the main artery. RCA is the main artery. RCA supplies the SA node. RCA supplies the AV node. It does everything. Okay? So it's very important to check for the RCA, right? So you go down in this L shape in this 12 lead ECG and you do that, right? So if you see it, it goes around like this. This is RCA, and then it turns, and then it becomes the posterior descending artery, right? It goes around the heart, and it becomes the posterior descending artery, right? So, and you can see how it sort of affects the 2, 3 AVF range, right? It goes down, and then it comes down again, okay? Now, because the posterior descending artery is posterior to the heart, what type of leads are you going to use? The posterior leads. These are the posterior leads, right? V7, V8, and V9. Okay, so as you see, 2,3 AVF and V7, V9. Okay, now because there's a positive deflection in this direction, right, to check for those leads, for that PDA, what will happen in these leads, V1, V2? You'll see a negative deflection, right? This will be negative deflection, and this will be a positive deflection. It'll correlate just the same. In that 12 lead ECG, you're not going to see V7 and V9. But if you see negative deflection, very intense negative deflection, that means V1 and V2 are, there's some sort of, pathology going on with the posterior descending artery. Okay, that's why they say here ST depression in V1 through V3 with tall R waves, because there was a infarction of the PDA. Does that make sense? Right? Infarction of the PDA led to some sort of abnormality, which you can either see on these leads or you can see on these leads.
Okay, so if it was it would be positive inflections for V7, V8, V9. It would be negative inflections for V1, V2.
Right. Okay. So whatever you're going to see opposite. Okay. So you're going to see ST depression in here, ST elevation in this guys.
Okay.
Yeah. All right. As I said, V1 through V4 is all LAD. As you go into V5, V4, V5, V6, you go into the LCX territory. Okay. Now, what is the main LCX territory? You see, because the LCX is going to go around the heart, so the lateral leads, which are the 1 and AVL, okay, that's why I've made it like this. So the two traces you're going to read are going to be like this, right? So 1 and AVL, you're going to read together. This is for the RCA, right? This is for basically LAD and LCX. LCX. Okay. All of this is basically LAD in a way. Make sense?
Yeah.
LAD and PDA. Yeah. All right. Now, if you understand this, now I can go into, first of all, diagnosing arrhythmias, and then going into antiarrhythmic simultaneously. Okay, because we have to cover a lot of these things, right? Now, in the next class, as I said, what I've planned is going through all of these ACS algorithms, coronary revascularizations, and all of this. Okay, so just wait for it, because these are the three things. Cardiology is, if I can teach you about heart failure and its treatment, if I can teach you about arrhythmias and its treatment, and then MI and its treatment, you're good. Okay, that's all, right? And because I teach in the way, like, I go into the depths of it, the exact physiology of it, that's why it takes time, right? But actually, it's just these three topics. Okay, so far so good. Everything is fine
for us.
Yeah, I mean, do you understand everything?
I think so. Content-wise, I just had a realization. I might need to book more classes with you.
Yes. Well, we'll talk about that after we're done. Okay.
Okay.
Yep. All right. So understand it like this, right? As I said, the only contact point where you can reach the electrical activity in the atria, can reach to the ventricles, is via the AV node. Okay. Whenever a depolarization wave goes through the AV node, it is called a narrow QRS complex. Why? Because it's using the anatomy of the heart. For example, you have the AV node, it goes into the bundle of His, right? Right bundle branch, left bundle branch, eventually goes into the Purkinje fibers, right? So all of those follow the anatomy of the heart, which means they're equally distributed, making a narrow QRS complex. Okay. Whenever there is a problem that is below the AV node, okay? So as I said, you can have a problem above the AV node, or you can have a problem below the AV node, right? If there is a problem above the AV node, it will give you a narrow QRS complex, right? And I just explained why, because it's following the anatomy, right? If something is giving you a wide QRS complex on the ECG, right, that means you have an issue underneath the AV node, and it's not following the anatomy. Does that make sense?
Yeah.
Right?
That would make sense.
So if I'm just going to use the diagram again. So imagine there was a foci, arrhythmic foci, in this region right here, right? Now, if this was the region, it'll go up here, and it will go downwards like this, the depolarization wave, right? Then it will go to the AV node, try to go back up, or it will go and supply it to the left ventricle by itself, right? So you can imagine the time taken for a wave to go from here all the way to up here. That's going to produce that wide QRS complex,
Okay.
right? But if it was just from here, it will produce that nice, compact QRS complex. Okay, because it's equally spreading in both directions, and you're having that vector in that lead to direction. Make sense?
Okay.
Okay. So now we understand that. So how are arrhythmias divided? They're divided between, first, bradyarrhythmias between less than 60 beats per minute, or tachyarrhythmias between greater than 100. Okay, that's the first difference. Now, bradyarrhythmias, you don't really need too much differentiation. It's usually just understanding heart blocks and stuff. We'll go into it. Tachyarrhythmias mean, for the first thing they mean is narrow versus wide. As I said, narrow means supraventricular, right? Or ventricular arrhythmias, right? So one is narrow QRS complexes or wide QRS complexes. Don't need to memorize it. I'm going to go through all of them. We got that so far?
Yeah.
Okay.
I just did my ACLS, so this isn't too foreign right now.
Okay, good, good. So I will, I would have to revise the ACLS with you if you need to, but now we're gonna make sense of all of this. Okay. All right. So bradyarrhythmia, right? That's the first thing we're gonna start with. Now, bradyarrhythmia, the first and the most common thing is just SA node dysfunction, right? If you have SA node problem, your beats are not gonna be organized properly, and you're gonna have bradyarrhythmia probably, right? Now, there's a diagnosis, if you've heard of it, called sixth sinus syndrome. Have you heard of that?
Is that when just the beats drop abnormally?
Yes, it can drop beats abnormally. Also, it causes bradyarrhythmia, right? So slowing and dropping of the beats, right? Why does it happen? Do you know the pathophysiology?
With age?
That's it, right? Age-related degeneration of the SA node leads to sixth sinus syndrome. Okay. Now that was the first diagnosis. What are the couple of other relations that can lead to bradyarrhythmia? Maybe drugs, right? Anything that causes parasympathetic output to increase will cause bradyarrhythmia, right? Ischemia or infarction of the heart can lead to bradyarrhythmia, especially what the RCA, because RCA controls the SA node and AV node. Make sense?
Yeah.
Okay, good. Next, increased vagal tone or vagal stimulation, right? Maybe you've seen, the hypersensitivity, carotid hypersensitivity, or, some sort of vagal hypersensitivity. Let's say they did a Valsalva maneuver, right? They were sitting on the toilet for too long, straining for too long, Valsalva maneuver, causing increased vagal tone, leading to bradyarrhythmia, right? So all of those can be seen, right? And it's all part of, physiology. What are you going to do for them? Now, if they're slow, I need to make their heart go up, right? So what I give them is something like an atropine drug. Why? What does atropine do? How does it work?
It blocks muscarinic, I think.
Right? Which is basically inducing sympathetic activity, leads to
Right.
racing of the heart, right? If there's severe nodal dysfunction, you might have to go for pacing, right? So you might have to insert a pacer in. Does that make sense?
Yeah.
Okay, good. All right, so we understood that. Now we go into AV block. So SA dysfunction is done, AV blocking, right? Now, is heart block understood, or do I need to go into it deep?
Let's try shallow first. Just
Okay.
briefly.
So I'm going to give you a good way of memorizing the heart blocks. Okay. This is how you memorize the heart blocks. This is the heart block poem, right? If the R is far from P, then you have first degree. Okay. It just means the length of the PR interval, right? Now, first of all, you tell me, what does the P wave mean again?
Atrial depolarization.
Okay. What does the PR interval mean?
PR? Oh, okay. I feel like the atrial repolarization is hidden within the QRS.
Atrial repolarization, I don't really, care about. ECG, doesn't really care about that. PR interval, where is the wave? Can you like visualize it for me? Where is the wave? You just caused atria to contract.
Oh, okay. So it went from the atria to like the apex?
No, to the AV node. Okay. PR interval, whenever they say PR interval, you have to remember atria depolarized, and now the electricity is going down to the AV node. Does that make sense?
R is the AV node?
No, PR interval, that length of time, right?
Okay.
That's the traversing between the AV node. Okay.
Okay.
QRS means QRS is completely gone through the AV node, and now it's going and depolarizing the entire ventricle simultaneously. Does that make sense?
That totally makes sense. Ventricle depolarization.
Right. And then it goes into T, which is ventricular repolarization. Do we understand that?
Yes, that makes sense.
So ST elevation means between the depolarization and the repolarization, there's a higher baseline of electrical activity. Does that make sense? Right. So because you have damaged the myocytes, they're not conducting their things properly, and they actually become they become very, very friendly with each other because you've damaged these cells. They conduct these electrical signals very easily, right? Not in an organized manner, right? So you reach a higher baseline. I'm just reviewing ECG with you, but you see ST segment elevation means you were here and now you've created a new baseline of electrical activity. Okay, so you're experiencing higher voltage because of damage to these cells. So it's not organized distribution of electrical activity. It's very disorganized and it's chaotic. Okay, reaching a higher baseline. Does that make sense?
Yeah, that makes sense.
Okay. All right. So now let's understand first degree. Okay. PR interval increasing in length, right? Typically, it's supposed to be low, but if it increases to 220 milliseconds, okay, I'm going to give you a better look at how the ECG should be interpreted, right? So you see 1, 2, 3, 4, 5, okay? And 5 small boxes makes this one large box, right? One of this is too big, but one small box, write it down somewhere, one small box is 40 milliseconds.
Oh, 0.4, yeah, okay.
Right? I remember 40 milliseconds. You can remember 0.4 if you want, right? But 40 milliseconds is one small box, right? And all 5 together is 200 milliseconds, right? What does this say right here? 220 milliseconds. So around that 5 box, right? So if I zoom in here, you see 1, 2, 3, 4, 5, and almost like 5.5 to 6, right? So that's what we're dealing with here. Does that make sense?
Okay.
Right. So that is first degree heart block, right? PR interval is increasing. It's taking longer for that wave to go through the AV node. That's all, right? Can it be seen in healthy adults? Yes, it can, right? Can it be, can it happen because of some sort of other etiology, some other problem, infection, myocarditis, etc.? Yes, it can, right? So there's a lot of etiology that goes into it. You might have to go over the etiologies and fix those etiologies. If there's nothing, then, you might not have to do anything, right? Lifestyle modification and all of that might fix it altogether.
Wait, one question. When they say AV conduction block, they mean between atria and ventricle, right? Not AV nodal block?
No, AV block, AV, which is AV nodal.
It is AV nodal block. Okay.
Yeah, yeah. Because the whole thing, right, all of this, right, is dependent on AV being alive, the node being alive. Okay. Next comes the second degree AV block. Okay, and let's go in further into the poem. Right, take a screenshot of this, by the way. Keep it with you. Make sure you visit it often, otherwise you will forget it. Longer drop. Then you have Venkenbach.
Yeah.
Okay, progressively lengthening of the PR interval, and then because you have lengthened it so much that the QRS complex is the ventricles undergo some sort of depolarization, or the bundle of his undergoes some sort of depolarization. Does that make sense?
Yeah,
Okay.
I've heard of longer drop for this.
Okay, good. So again, what are the etiologies? You see reversible ischemia. It can be high vagal tone. It can be RCA-mediated ischemia. Any sort of drugs that increase the amount of parasympathetic output too much, right? Maybe infection, maybe autoimmunity, right? One of the main questions they would like to ask you is SLE, right? SLE leads to heart blocking, right? It damages the heart, the AV node a lot, okay? Leads to, it can happen as like heart block like this type, or congenital heart block in mothers who've had SLE. Okay, so babies are born with heart block because the mothers have SLE, or maybe even drug-induced lupus. Okay, so remember that correlation, write it down somewhere. SLE, you see, we'll talk about all the SLE causes and stuff when we go into rheumatology, but carditis, pericarditis, myocarditis, right? Liebman-Sachs endocarditis, making valve vegetations, causing heart block are just the tip of iceberg for SLE, right? So make sure you know every cardiac aspect of SLE. Okay, if you want to write it down, write it down. Pericarditis, myocarditis, Liebman-Sachs endocarditis, right? Heart blocking. So these, at least these four, you should know and readily remember. Okay,
For SLE specifically?
or SLE, yeah, lupus. Any autoimmune disorder can sort of mimic what SLE does, but SLE is the granddaddy, right? So we're gonna have to remember that.
What was it again? Myocarditis? Liebman endocarditis?
Liebman-Sachs endocarditis, yes.
I think you're missing two. Myocarditis, Liebman endocarditis, and then
So
pericarditis?
yes, pericarditis, myocarditis, Liebman-Sachs endocarditis, and heart blocking.
Oh, heart blocking. Okay.
All right. Now, moving forward, we have Mobitz 2, right? Which is if some P's don't get through, then you have Mobitz 2. Now, there is no lengthening here, but then there is an abrupt disruption of the P wave producing a QRS wave. Okay. So what you have to do is you have to count how many P waves are there and count how many QRS waves are there. If there is a discrepancy, then you have, Mobitz 2. Okay. So as you see here, this is what 4 P waves for 3 QRSs. Okay. So this is a 4:3 conduction pattern, right? Now, when I look at over here, I see 1, 2, 3, QRS waves, right? But then I see, I think 1 here, 2 here. I'm sure there's 1 going in this. There's 1 going in this, 1 going in this. So for every 3 P waves, I'm seeing maybe 1 or 2 QRS complexes. Okay, so the ratio is very weird, right? So now some P's are not getting through, right? So that is Mobitz 2. Do we understand Mobitz 2?
My understanding was just longer drop and then random drops for type 2.
Yes, yeah, random drops, yeah, right. So some of the P's are not coming through, right? That's what they're saying, right? But yeah, most of the P's are going to come through, but randomly they're going to abrupt. Okay, all right, it's the same amount. The etiology is just the same, right? But you may have like overlapping things, and the thing is, it can progress. Someone can start with Mobitz 2 and end up with third degree heart block. Okay, so if it is like, let's say if it is an MI problem, right? Let's say if it was a RCA ischemia, right? You started with Mobitz type 1 and now you've gone into third degree heart block. So they do progress into each other. Okay, they can transition between each other. Just remember that. Sometimes people are like, well, he has this type of heart block and that's it. No, it can get worse, right? It can go into third degree, right? So third degree means now you have complete AV dissociation. Atria is doing its own thing, ventricles are doing their own thing. You understand that, right? So if P's and Q's don't agree, then you have third degree. Again, count the number of P's you have, count the number of QRS complexes you have. They should have constant P to P interval, and they should have constant R to R interval, right? And the relationship between PR interval is not non-existent. It can be variable. Okay, does it make sense?
Yeah. So
Right,
like
good.
a ventricular foci took over?
No, the thing is, you see, if SA node works, right? SA node has its own capability of producing beats. AV node has its own capability of producing beats.
Oh,
Similar to that, your bundle of Hises have their own capability. The Purkinje fibers have their own capability. Okay, the fact that AV node, SA node is working that way, that's why AV node works. If SA node tomorrow never worked, then the AV node will work. If the tomorrow AV node doesn't work, then the bundle of His will work. If that doesn't work, Purkinje fibers will do it themselves. Do you understand?
okay. So something else took over.
Right. So there's always a fallback plan, but you don't want it to reach that plan. Okay. So there's automaticity in all of those, not just at the nodal level. All right. Now we're going into supraventricular tachyarrhythmias, right? Everything above the AV node. Okay. First thing is just sinus tachycardia, which just means greater than 100 beats per minute. The main thing is, and I need you to learn this, you know how when a young female comes to you with abdominal pain or pelvic pain, what's the first test you do? Beta HCG, right? I want to see if they're pregnant or not, right? Take that same mentality and put it into this thing, right? You're not testing for beta HCG, you're actually testing for TSH. Okay. Thyrotoxicosis is one of the most common reasons for a person to come in and have uncontrolled heart palpitations, right? So either it's a panic disorder, one of the most common, or they have something like thyrotoxicosis or hypothyroidism. So what are you going to check for? TSH. And what is the TSH supposed to be? Is it high or low?
In them?
Yeah.
Maybe low for
Right.
negative feedback.
Right. You have to be more confident in your answers, right? You know these things, you know how they work, you know how they are, right? So you have to make sure you're more confident about them. Okay. All right. So as I said, if you're diagnosing an arrhythmia patient, first thing is check for TSH. That's how you practice. Okay. Next thing is if they're showing you signs of pheochromocytoma, pregnancy, anemia, all of that. Yes, that can explain whatever you're seeing, right? But have that explanation ready. Is it drugs? Is it this? Did they have cocaine? Did they have that? What did they have? Right? That's the gist. Okay. All right. Now, next comes something called premature beats, right? There's something called premature atrial contractions, and then there's something called premature ventricular contractions. Okay, both of them. Now, you tell me which one's is going to be narrow complex and which one is going to be wide complex,
Okay.
or both of them narrow or both of them wide. What is happening?
Premature beat sounds like SAAV node, so it should be narrow complex, right? Because it's supraventricular.
Right. So,
Premature contraction.
so there's premature atrial contraction and there's premature ventricular contraction.
Okay. PAC should be definitely narrow complex because the problem is above the nodes.
Exactly.
Premature ventricular contraction should be wide complex because
Exactly.
abnormal electricity impulses.
Exactly. You see what happened? This was the regular interval, and this one came out of nowhere, right? But it's still following that pattern. You understand? Right? Still looks like a correct ECG. I don't know why it happened quickly, right? It happened ectopic. There was an ectopic foci in the in the SA node maybe, and just abruptly led to depolarization. Sure, right? But it's still going to follow the anatomy, right? Whereas you see this is a PVC, right? One end of the pole, right? This was the foci, produced it. It has to go through all of this length in order to make that. That's why it's so wide. Okay, wait, this makes sense. AC,
Yeah,
PAC, PVC. All right. Next comes atrial flutter. Now, the diagram you need to see is atrial flutter versus atrial fibrillation diagram.
when is sawtooth? When is like abnormal impulse?
Right. Now, what I need you to visualize though is how they circulate through the ventricles. Okay. Sorry, the atria and the ventricles. Right. So let me just find the other one. So when you have atrial flutter, the atrial flutter is a cycle within the right atrium going round and round and producing the depolarization in every turn. Okay. Does this make sense? This is atrial flutter. Whereas atrial fibrillation is multiple foci, at least greater than 3, right? Can be in any place within the atriums, and that produces this very weird depolarization, and that leads to constant activation of the AV node.
Wait, one more time. A flutter is cycles of electricity impulse between SAAV node.
Right. And fibrillation is multiple foci that produce activity within themselves and cause the AV node to depolarize. Okay. Please take a picture of this. Keep it with you. It'll help you remember. Or if you can just burn it into your mind.
For A flutter, cycles of abnormal impulse between AV between SA and AV, right?
Right, right. So this is just a this reentrant cycle that has taken place. Now, why could that be? Right, it could be because the fibers were stretched. Right, maybe the atria was dilated. Maybe there was a previous history of cardiac surgery. Maybe there's infection. Maybe there's autoimmune damage to the wires of the heart. Right, maybe there was chronic hypoxia led to some sort of there's no perfusion of those nerves in the heart. Right, led to aberrancy, and then there's this cycle going on in the heart. Okay. Now, if
This
you look at
actually explains it so much. That's why in A flutter, there's like a big wave and then multiple small
exactly,
waves, right?
that's it. You figured it out. This is one cycle. This is another cycle. This is another cycle, and finally, an AV node is released.
Okay.
Okay. Next, now you figured all of this out. I'm going to go into the antiarrhythmics and how to fix it soon. Okay. Now, what is the main thing you're going to check? Because you're looking at the RCA, because you're looking at the SA node, 2,3 AVF, and of course, you're going to have narrow QRS. Does that make sense? Good.
For A fib, A flutter?
Yeah, because they're all SA node, AV node, right? You're going to have to check 2,3 AVF. Okay. Now, treatment of atrial flutter and atrial. So going forward, I'm going to go through, the antiarrhythmics and stuff, right? So I'm going to introduce it right now. Okay. So the introduction of these things, right? First thing is, I need you to look at a pattern, right? The pattern is, do you know how the phases of these depolarization work? Do you know the phases of these?
Yeah, it's by electrolyte, right? So,
right. So which one's coming in, which one's going
out? Potassium, and then it'll transition to calcium, and then it'll resume with potassium.
That's it. Okay, we understand that. Okay, good. Now, is this nodal graph? Is this taking place in the nodes, or is this myocyte graph?
Myocyte.
Good. Okay, so look at this. Class 1 is all myocyte graph, but then here comes class 2. This is what? Nodal graph.
Oh,
okay. Now you come in class 3. This is myocyte graph, and then you go into class 4, nodal graph. So we can always remember class 2. All the even classes, they affect the nodals. Okay, the nodal tissue. All the odd classes of antiarrhythmics affect the myocytes. Can we make that distinction? Okay. Now, let's go over the evens first, because you'll see them mentioned over and over. Class 2 is beta blockers. Okay. How do beta blockers do this? The beta blockers decrease CAMP inside the cell, which is, they inhibit the G stimulatory, leads to low amount of calcium in all of the cells, leads to less amount of contraction and less amount of conduction. Okay. Leading to, and where do they all act? They act at the AV node. Okay. So as I said, if AV node takes longer time, how do you see it? PR interval. Okay. So what they're basically saying is, I'm going to slow down, right? Imagine there's a, speeding car. How do the police, they slow it down? They put like those caltrops and like they drop that thing that punctures their tires, right? That's what class B is basically doing, right? If there's something very fast that's about to come in, it basically slows it down. Okay. Make sense?
Yeah.
Right. So where do we use it? That's the most important question. And then contraindications. All these beta blockers and the contraindications, they take a lot of time to explain. I'm just going to introduce them to you. If you can figure it out between the next class and now, great. Right? If not, I'll go over them. Okay. The first thing is, you obviously have to use it in anything that requires a nodal excitation. So almost every supraventricular tachyarrhythmia, you can use beta blockers. But the thing is, you cannot use it in all patients. Why? Because beta receptors are, they control a lot of like metabolic lungs. Okay. They control like lipolysis and all of that as well. So we have to make sure we don't give this to certain groups of patients. First of all, you cannot give it to patients who have COPD and asthma, right? Especially if it's something like non-selective, right? Do you know which ones are non-selective and which ones are selective?
For Panolol, is non-selective?
Is that the only one you know?
Maybe Timolol?
Okay, so here's how you understand it. From A through N, right? A through N. No, A through M, my bad. A through M. A through M is selective. So metoprolol, esmolol, atenolol, right? All of these are selective. N through Z is non-selective. Can you understand that?
Yeah.
Okay. So N, right? Non-selective, right? There are a couple of exceptions to this rule, but generally, if you forget about what is what, just remember A through M and then N through Z.
Okay.
Okay.
Yeah, I got lucky with Timolol. That was it, guys.
Yeah. So both of these, especially if you have non-selective, can damage the beta 2 in the thing that keeps the bronchioles open, right? COPD, asthma, you cannot use them. If someone already has heart block, why would you give them beta blockers? Do not do that. Okay. If someone has dyslipidemia, because beta blockers, the beta receptors control lipolysis, right? Because understand like this. If someone needs energy, right? They're under emergent situations. They need energy. They're going to break down their fats. That's what beta receptors do, right? But if I give them beta blockers, the fat is going to store, right? The fat is going to mobilize. So if someone already has, dyslipidemia, giving them beta blockers is contraindicated. You can precipitate an atherosclerotic event. Okay. There's a couple more diabetes people you have to be careful of. If someone is receiving insulin, if someone has hyperkalemia, you have to be very careful of them, right? So a couple of all these scenarios I'll go over when I do beta blockers, but go ahead and write it down for yourself. Contraindications to beta blockers. Okay. Very important topic, right? Fourth, the class 4 is calcium channel blockers. Okay. Now, these two calcium channel blockers versus the other calcium channel blockers like nifedipine, nicardipine, right? Those are called dihydropyridine receptors, right? That's why they have the dipine in the name, dipine, dihydropyridine. Okay. These are non-dihydropyridine. Okay. Now, the difference is that dihydropyridine receptors, DHPR receptors, are located on the vascular structures, right? So if I give them nicardipine, nifedipine, and all of that, that leads to vasodilation. That leads to lowering of the blood pressure. Diltiazem and verapamil have their receptors located at the heart, in the heart. Okay, so both of these will lead to just slowing down of the heart, right? Decrease the amount of calcium within the cells, decrease the amount of velocity, and the overall, maybe even the contractility of it. Does that make sense?
Yeah, I think so.
Yeah. So adverse effects is the same with all CCBs, but now you see constipation, very, very important. Gingival hyperplasia, right? Similar to phenytoin, right? There's a couple more drugs that lead to gingival hyperplasia, but if your antiarrhythmic is leading to gingival hyperplasia, make sure you change it or something, right?
Wait, what's gingival hyperplasia? Blackening or bleeding?
No, your gums are just becoming hypertrophy.
Thicker?
Right? Yeah,
Okay.
thicker. There's this question in UWorld which you will see. They will say the length of the enamel versus the length of the gum, right? They don't say the gum. They say some, and they say it in very obscure like medical terminology, was decreased, right? The ratio of the teeth versus the ratio of the gum
That's
was,
crazy.
yeah, they talk to you about like that. And then you are supposed to get gingival hyperplasia and the person was on phenytoin. Okay.
So you stop the medicine in that
Yeah, you
case?
stop the medicine or you can change it. Yeah. All right. So in especially AMBOSS, okay, what ends up happening is they like to compare the graphs a little, right? So understand it, look at the graphs, right? And that's why I've highlighted it here too. When it comes to class 2 antiarrhythmics, they increase the phase 4, right? Which means the funny currents that are supposed to go in and depolarize the nodal wave, that is going to be the most affected, right? Prolonged repolarization of AV node, yes. So it will take time. So if I, show you, so you see, this will take time to come, and depolarize, right? Sorry, repolarize, right? But it'll also take longer to depolarize, okay? Where as you look at this graph, you see, this does not, calcium channel blockers do not affect the depolarization too much, right? But they definitely affect this area a lot, okay? The repolarization is affected a lot, right? So in certain NBMEs and these AMBOSS questions, they're very picky about how you sort of interpret these graphs. So I need you to look at this, the waves of these, okay? So you see how, intense the slope is, the repolarization slope, whereas this is not that intense. So they might ask about these things.
That's for beta blockers.
Yeah. All right.
So
So
beta blockers prolong depolarization.
right.
CCBs prolong repolarization.
Yes. Okay. All right. So when we talked about atrial flutter, now you see how you get the rate control, right? Beta blockers, calcium channel blockers. Okay. They've also mentioned digoxin. It's important for us to go over digoxin as well. Okay. So digoxin does not have an antiarrhythmic class, right? Because it doesn't directly work on any sort of sodium channel activity and stuff like that. It works on exchangers, right? The exchanger that it works at is the sodium potassium ATPase. Okay. What that sort of leads to is it leads to high sodium inside the cell, and then it fails, it opposes the gradient that is required for the sodium calcium exchanger to work, which ultimately leads to the calcium not working, right? Because you see what it's done is sodium is already increased. It cannot push sodium against its will inside the cell, which means it cannot push calcium outside the cell, right? So calcium stays in, right? Now, calcium staying inside a myocyte means contraction. Wherever calcium is increased, it means contraction, right? So calcium increases, contraction increases. Now, what place do you think, right, is the most important when it comes to requiring contraction? We went over the PV loops last time, right?
I'm sorry, I don't understand the question. What
So,
place is important for contraction?
right. So if I give
Ventricle?
someone digoxin, so what'd you say?
The ventricle?
Yes. So the thing is that I'll rephrase my question. What diagnosis requires the contraction to be increased, right? So when we went over that PV loops, you
How
remember?
come?
What'd you say?
How come?
Um,
Hypertrophic obstructive?
no, no, no. I'm okay. I'll just say it and I'll rephrase it again. I'm talking about heart failure. Okay.
Okay.
Within heart failure, if you give someone digoxin, it will end up increasing their contractility, right?
Yeah.
It will increase their slope of the PV loop. You remember that thing that we talked about, right? It will
Okay.
increase that, increase the cardiac output. Okay. So one of the main drugs that's used for heart failure therapy is digoxin.
It slows conduction, increases strength of contraction, right?
So yes, the first effect that I'm talking about, contractility, is based on this calcium physiology, right? The second effect it leads to is parasympathetic being increased, right? Stimulates the vagus nerve, causes bradycardia. Okay. Now, if you lead to bradycardia, yes, you're gonna have higher diastolic time, you're gonna have better filling, and then you're gonna have better contraction and workload balance, right? So heart failure, it's used very well as a heart failure drug, but it can be used for something like supraventricular tachycardia. Does that make sense? All the physiology?
We're just saying it can work for SVTs.
Yes. SVT, but the main use for it is heart failure.
Okay.
Yeah. All right. Now, understand a couple of behaviors of digoxin. Digoxin is competing with potassium at this receptor. Okay. So whenever you have hyperkalemia, digoxin cannot go in and sort of affect that transporter too much, right? But if you end up having hypokalemia, digoxin binds very, very well. Okay. So if someone, what's one of the drugs you end up giving the heart failure patients? It's a lot of diuretics, right? And if you give those diuretics, you cause hypokalemia, right? And that hypokalemia, and you also decided to add digoxin, the hypokalemia will lead to higher amounts of digoxin activity. Does that make sense? I'm
Wait,
building.
okay, wait, 1 second. We're
Mhm.
saying digoxin keeps potassium out of cells. So in heart failure, when we give them diuretics, they can have hypokalemia because
Mhm.
all of the potassium's outside of the cells and can be flushed now.
Mhm.
Okay.
Yeah.
And then the second point, I didn't understand after that.
So, do you understand the relationship between digoxin and potassium?
Yeah, it keeps the potassium out of the cells, right?
Yes, but as I said, digoxin and potassium compete for this receptor. Okay.
Okay.
So if someone
Okay.
has hyperkalemia, digoxin levels will be, maintained, right? It will compete at this receptor.
So it blocks it from entering the cell again because it's competing for the receptor.
Exactly, right? If someone has hypokalemia, it will lead to digoxin binding very, very easily. Higher amounts of digoxin toxicity can occur. Does that make sense?
Okay.
Right?
So digoxin binds the sodium potassium ATPase
Right.
and then prevents potassium from re-entering.
Right.
And then we're saying it's worse for hyperkalemic patients.
Well, worse what? Is it digoxin toxicity you're talking about?
Um, no, so I was saying if someone's hyperkalemic, it'll worsen the hyperkalemia.
If someone is hyperkalemic, yes, yes, yeah, yeah, it can worsen hyperkalemia. Yeah. Right. So, and if someone is hypokalemic, you will get digoxin toxicity.
Ah, that's what you were trying to say. Okay. If someone's already hyperkalemic, then they get digoxin toxicity.
If someone is already hyperkalemic, do they get digoxin toxicity? No. Think about it again. You're confusing yourself. Okay. If you have hypokalemia, digoxin binds to the receptor easily. If you have hyperkalemia, digoxin doesn't bind to the receptor easily.
Because there's more to compete with.
Yes. That's it. Keep it simple, right? Everything else that happens because of digoxin, keep that separate. We're talking about, metabolic problems
Yeah.
affecting digoxin, right? Not the other way around. So just talk about one arm of the problem. Okay.
So were you trying to say with low potassium, there's easier to get digoxin toxicity because easier binding?
Yes.
Okay, I definitely didn't hear that. Sorry, my bad.
Okay. All right, so we understand that, right? So anything that leads to hypokalemia, it can be renal failure, it can be diuretic use, it can be X, Y, Z, right? Anything that leads to it will lead to digoxin toxicity. Does that make sense?
Can you say that again one more time? Sorry.
Yeah. Anything that leads to hypokalemia
Yeah.
can lead to digoxin toxicity. It can be renal failure, it can be diuretic use, it can be high or low aldosterone or something like that.
Okay.
Like, no, high aldosterone. It can cause that effect. Okay.
Okay.
Yeah. All right. Now, lastly, as I all of that is mentioned over here. Okay. All of that, whatever I said, is mentioned over here. Okay. Now, because it leads to parasympathetic activity, it leads to cholinergic effects, right? So you can have anticholinergic effects taking place, right? Nausea, vomiting, diarrhea, right? It starts with that, and then it eventually goes into something like yellowing of the vision. Okay, so that's a characteristic trait that you may see with these digoxin toxicity. Okay, now
Okay.
how do you fix it, right? If someone has digoxin toxicity, how are you going to fix it? The main thing is fix the potassium, right? If they have hypokalemia, give them KCl, right? Give them KCl in their saline, right? If they're actually very, very, they have fibrillation and all of that, maybe cardiac pacer. But the main couple of treatments that you're supposed to say is magnesium, because that will prevent, this calcium effect, right, that you're seeing in the cell, and then anti-digoxin fab fragments, which is basically, how an antibody looks, right?
Mhm.
This is the FAB region, right? This is the FC region, right? So you take this, and if you make the antibodies bind to the digoxin, they will precipitate, and you can renally excrete them. That's the physiology behind anti-digoxin fab. Okay.
Okay.
All right. So we understood how digoxin works. Great. Now, as we go down, all of this will become easier and easier because the treatment sort of remains similar, right? You have to manage their contraindications and indications, but now we understand the overall aspect. Okay. Multifocal atrial tachycardia, right? It's the precursor of atrial fibrillation. You see how in atrial fibrillation you had like 5, 6, 7, even more than that, places depolarizing, right? With multifocal, they have, different places, but mostly related to greater than 3 or a little bit more than that. Okay. And what they can do is they can produce P waves distinctly, right? So P waves, from one location to another location to a different location. So 3 different places are sending P waves constantly. Make sense?
Multiple P waves on
P
each.
waves from, different locations. Yeah. Make sense?
Yeah.
Okay. One of the main things you will see with these fibrillations and stuff, right? COPD, hypoxia is one of the main sort of etiologies to this, right? And you should imagine why. Hypoxia can lead to, coronary vessels not getting enough oxygen, right? They can damage the heart. They can damage the electrophysiology of the heart, right? So hypoxia in general or COPD is very, very, it can prone a person to fibrillation, tachycardia, tachyarrhythmia, all of that. Okay. Always remember that correlation. You got that?
Okay.
Yeah. Okay. Now we go into atrial fibrillation. Okay. AFib, we understand the diagnosis, we understand how it works, we understand what we can do. Now there's a couple of scoring systems they use to categorize what is the risk of embolism brought on by AFib, right? Because you see, all that blood is not actually going anyplace, right? It's just sitting there, and it can just sit there and coagulate, right?
Yeah.
And eventually you may send it into the arterial system, cause a stroke or some sort of mesenteric ischemia, this ischemia, that ischemia, whatever. Okay. So the risk, and whenever you see any sort of risk prediction or any sort of factor that you're supposed to remember, right? First, break it down. Okay. One thing that they will give you is demographics, right? Demographics are very, very easily correlated with any of these risks, right? Next thing is comorbidities. Okay, comorbidities. So in all of these risk factors, you'll see comorbidities. Okay. Next thing you'll see is previous history. If someone has a past history of something, it's automatically going to be correlated. Okay. So always, categorize these scoring systems based on at least these 3 aspects. It'll help you remember them better. For example, if someone has, let's do demographic. If someone is 875, okay, demographic, right?
Mhm.
I can remember that. Okay. If someone has diabetes or hypertension or even congestive heart failure, okay, comorbidities, right? If someone has a past history of what? Stroke, I now remember the whole CHADS2 scoring. Okay. So this is how you sort of remember it. Okay. Demographic, comorbidity, and previous history. Make sense? So now as you go forward, what is then you remember the weights of it, right? So I'm giving 1 point to someone who is very old, 75, right? I'm giving 1 point to someone who has comorbidities, right? But I'm giving 2 points who's someone who has had a stroke prior. Okay. So that is CHADS2 scoring, right? And if you score high, what does that mean? I'm going to give you anticoagulation right away. Right. So out of 1, 2, 3, 4, 6, right? Out of 6 points, if someone is at 4 to 6, I'm going to give them anticoagulation, heparin, right away. Understood?
Yeah.
Okay. Is this getting too much?
No, I've seen this before in like school presentations,
Yeah.
but it makes more sense when we just did the arrhythmias and stuff like that. For
Yeah.
some reason, it's
Yeah.
clicking more.
And I want you to start to remember it, right? Use logic to remember it, because a lot of people are like, what does the C stand for? What does the H stand for? Understand the logic behind it and apply that logic, right?
Yeah.
Once you have the logic behind it, it seems easy. Okay.
Yeah, it's
It seems
better now.
intuitive. Yeah, it seems intuitive, right? Okay. So Now, what are the management goals and the stuff you need to do? You can read all about it, but I'll give you the overall, treatment protocol, right? It's called the RACE protocol, but don't have to remember the acronym. The main thing is, first of all, I'm going to control the rate, right? I'm going to control how fast these things depolarize, right? The nodes are depolarizing. And what am I going to use? I'm going to use the drugs that target the nodes, right? Class 2 and class 4. Okay. Now, they've added digoxin here because digoxin has shown that AFib can be controlled, right? But those 3 or 4 drugs, that's the main ones that I'm going for, right? If patient has heart failure, then I'm especially going to go with digoxin, right? The last thing is amiodarone. Similar to, and I'll give you a correlation here. You see, when I teach anti-seizure medications, there's this drug called valproate, which works through every mechanism of seizure, anti-seizure pathways, right? Similar to that, the valproate of anti-arrhythmics is amiodarone. Okay, amiodarone works through class 1, class 2, class 3, class 4, everything. Okay,
I knew that about amiodarone. I didn't know that about valproate. It has multiple methods.
So valproate blocks like sodium activity, it blocks calcium activity, it includes like GABA activation, all of that. Okay. So that's, I'm comparing apples to oranges, but remember, both of them are, multi-physiologic drugs.
Okay.
Yeah. All right. Now, next thing is, if I've controlled the rate, I have to control their anticoagulation. We use CHADS scoring, and then eventually go into CHADS VASIC scoring as well. We'll go into all the scoring system when we do MI. Okay. But right now, CHADS 2 scoring is enough, right? What do you do? What do you give them for anticoagulation? You can start with oral formulations of all these drugs, right? Apixaban, dabigatran, rivaroxaban, right? It blocks the 10A activation, right? Doesn't allow the cascade to go down further, no clots, right? Or you give them the bridging therapy and introduce warfarin into their system. You know what bridging therapy is?
I think you do initial heparin and then add warfarin.
Exactly, right? So bridging therapy going into warfarin, right? Keep them on long-term warfarin if they're really, really prone, right? If not, if they have mild, they're less than 65 years of age, no CHAS2 risk factor, then you give them aspirin. Make sense?
Sometimes they do dual platelet or antiplatelet stuff.
Yes.
That's for stents.
Yes. That's for stents. Yeah. Okay. Next thing is, if the rate is not coming, down, right? Then you defibrillate them. Okay. What's the protocol to do that? If the AFib episode and if the AFib has taken place less than 48 hours, right? If it's less than 2 days, then you do it without anticoagulation, right? Because imagine this, they've had AFib, right? And then you defibrillate them, the heart kicks back again. Whatever clot they made, you're gonna force it into their system. You understand, right? Mm-hmm. So if it's been small amount of time, then you can defibrillate them and don't worry about it. Okay, but if it's been longer, greater than 48 hours, you have to anticoagulate them. Make sure they're anticoagulated for that long amount of time. Okay, then you can defibrillate them. Does that make sense?
Yeah.
Okay, so the only difference between when to and when not to is how long has it been. Okay.
Yep.
And lastly is fixing the etiology. Why did this start? Is it because of COPD? Is it because of thyroid? Is it because of heart failure? Why did it start, right? I'm going to target that. I'm going to fix that. Okay. Now, this is the sort of protocol that they've given you. Let's just review it. This is just CHAD scoring, right? And when do you actually start what sort of therapy, right? If they're good in age, that means they're greater than 75, right? I can start oral anticoagulation. If they meet all this, yes, I can start anticoagulation. But if they have an extending coronary or peripheral arterial disease, I may have to start antiplatelet therapy. For example, clopidogrel, prasugrel, right? All that. Okay. So when do you move away from oral anticoagulation to antiplatelet? If they already have a PAD or a CAD in their system. Does that make sense? So don't get confused and don't think of it as facts, right? Imagine this: if CHAS2 was 6, right? Are you still gonna just do oral anticoagulation, or if they have like widespread atherosclerosis, they've had high cholesterol for 20 years, right? At that point, you have to increase the amount of therapy you give them. That's it.
Makes sense, right?
Yeah. So make sense out of it. All of these diagrams, you can look at them day and night and not remember them. Okay. If you make sense out of them, it'll stick with you, right? All right. Next, all of this is very, very intricate. All it basically says is when are you gonna cardiovert them and when you're not gonna cardiovert them. So I'm not gonna use this. I'm gonna use like the clinical algorithms maybe in the next session to review some of this back. But right now we don't need to get into it. Okay. Now, what is the end-all treatment? If there are multiple, places generating these depolarizations, I'm gonna go in through surgery and ablate them, right? I'm gonna destroy these centers one by one and make sure they don't produce any depolarizations. Okay, so cryoablation, radiofrequency ablation, and then laser ablation, whatever.
This is AFib still, right?
Yes. Okay, this makes sense now.
Um,
Ablation
yeah,
stuff. Okay,
yeah.
so eventually you see this, the approach to therapy, when do they actually undergo catheter ablation, right? It's the end all, right?
Mhm.
Eventually, you have persistent atrial fibrillation, or you can have paroxysmal atrial fibrillation. It's the end all therapy for atrial fibrillation. But till then, you're going to make sure you control their rate. You're going to make sure you give them anticoagulation. If they've reached the acute stage, you might have to cardiovert them. That's all the principles are. All of this is just that, right? Optimize rate control. Symptoms persist, then you cardiovert them. If they improve, then you manage the therapy with, I think, what is AAD therapy? I don't even know, right? But then if it doesn't, then you go into ablation, right? If it does, then you control the rate for long term. Simple, right? Keep it simple. Don't get caught up in the semantics of things and forget the sense behind it. All right. All right. So let me finish the supraventriculars. We'll go into the ventriculars in the next class. Okay.
Okay.
Because I know it's getting a lot, right? Now understand it like this. There's two diagnoses. There's AV nodal reentrant tachycardia and this AVRT, which is atrioventricular tachycardia, reentrant tachycardia. Okay. People get confused in them all the time. AVNRT versus AVRT. Okay. The key word being nodal, N in AVNRT. Okay, nodal means that this is taking place at the AV node, in the AV node. Okay, now because it's in the name reentrant, it means there is a cycle that is independent of AV node's control, just going round and round, as you see here, right, like a racetrack, is going round and round within the AV node. Now you should ask me, why did this happen? Well, it can be infection, I don't know, infection, radiation, autoimmunity, whatever. All the things that I've been saying all this time, it can happen because of that, right? Previous history of MI, maybe that's why it happened, right? But within the AV node, you've made this racetrack go round and round, and eventually it leads to higher depolarizations. Okay, that is AV and RT, right? Now, just so we understand each other, you see, this is the lead to, and this is the cardiac vector, right? If there is a depolarization that goes away, as you see here, it's going away, right? How will this P wave, or let's say whatever wave it produces, how will this look? Will it have a positive deflection or a negative deflection if it's away from the main cardiac wave?
Positive?
No. So you see, lead to is in this direction, right? So if anything was in this direction, it would produce positive, right? If it's in the opposite, it'll produce a negative deflection.
Okay, okay.
Right? So if you look at the ECG of AVRT, right, this is AVNRT, but AVRT can also produce retrograde P waves. Okay, so it will actually produce a negative deflection in the ECG. Does that make sense? Sorry, this is AVNRT. Yeah, so the P waves are negative in deflection. Does that make sense?
Because they're moving backwards.
Yeah, they're away from the lead to, right? As you see here, right? The depolarization is going in circles, right? At some point, it's going to be, correlated with that lead to, but at most of the certain points, it's going to be away from that lead to, right?
Okay.
Yeah. Right. So that is AVNRT, retrograde P waves, and then you look at the therapy and all of that. Increase the vagus activity by Valsalva maneuvers, vagal maneuvers, right? Carotid massages, etc. Right? Or as we've seen so far, control their nodes, right? You can add flecainide and propofenone. All of these are class 1C drugs. We'll talk about them next time. Okay. Now, lastly is AVRT. Okay. AVRT means that there is a secondary channel apart from the AV node that is allowing passage of electrical activity. Okay. One example of AVRT is Wolff-Parkinson-White syndrome. Have you heard of that?
Mm-hmm.
Right. So whenever they ask you, right, what is a type of AVRT, you're going to say WPW, right? Now, as I said, there is a secondary tract. Whenever we talk about AVRT, there's a secondary tract within the heart, right? Apart from the AV node that is conducting these electrical activities. Now, what is the secondary tract in WPW? Do you know?
Bundle of Kent.
Bundle of Kent, right? And then you see where the bundle of Kent is located, right? It's a specific location. It's a specific, that's why, WPW is famous, right? Within this, you'll see not just electrical activity going through the AV node, it's going through this place as well, right? Now, because this, AV node slows it down, it's like a roadblock. This thing is just a highway, right? This is going to go fly through it. That's why you see the depolarization is very, very quick, upstroke. Make sense?
It goes through the left atrium and back into the Purkinje's?
Yes. It goes directly into the Purkinje's, causes depolarization right away, ventricular contraction right away. Does this make sense?
Yeah.
All right. Now, what this does is, you see, this is non-directional, or you can say bidirectional, right? It doesn't have a direction. It can go this way, it can go the other way too, right? Now, if it goes this way, that's one thing, but what if it goes the other way now, right? Let's say the AV node was conducted, right? Both of them are spread equally, but then this Purkinje fiber led to the bundle of Kent receiving that and sending it back to the AV node, right? You've just created what? Atrioventricular reentrant tachycardia. You understand?
Yeah.
Right? So same thing as you saw with AV and RT. Again, the depolarization is away from lead 2, which means it's going to have retrograde P waves.
As well, because it's bidirectional conduction.
Right. So in this like counterclockwise fashion, it's called orthodromic, counterclockwise fashion, you're going to see that retrograde P wave, right? But there is this type, antidromic, which just means that the reentrant tachycardia is clockwise, right? Are you going to see retrograde P waves? No. What you're going to see is first the upstroke, then the depolarization, and then you will see this pink wave taken over. So you see first the upstroke, then the depolarization, which is up, and then because you're going away from the lead 2 again, right? You're going away from the lead 2 again. Let's see the negative depolarization bringing it back. Wide QRS, and then the 3 parts of the ECG. Is this good?
So in the bidirectional, you don't see delta wave?
No, in this one, yes, you see the delta wave. In this, no.
But the right one isn't bidirectional anymore.
You mean this one?
Yeah.
No, both of them are, you see, bidirectional is the quality of the bundle of Kent. Okay. So don't associate that with any of these, right?
Okay.
This means there is clockwise flow. No, counterclockwise flow, and this is clockwise flow through there. Okay. And
Can you zoom out for a second?
Sorry?
Can you zoom out for a second?
Yeah.
But see, for the right one, it's flowing through the bundle of Kent in one direction. That's why I was saying, oh, if it's unidirectional through the bundle of Kent, it's going
to happen one at a time, right? It means bidirectional. It means it can flow downwards and upwards, but one at a time. If it's caught in a circuit, it can only go in that one orientation. You understand?
Like I think WPW or whatever this one's called, Wolf Parkinson, it happens in episodes, right?
Yeah, it can. Yeah.
So are the episodes the middle heart where it's like flow is erratic and everywhere?
No, you cannot tell which one's which without the ECG. Okay.
Okay.
You cannot tell, right? Because both of them are going to present with the same. You're going to have, cardiac flow being disrupted. You're going to have, the patient having palpitations, heart racing feeling. They're sweating. They're going to think they're having a heart attack. Maybe some chest pain. The symptoms are very general. But when you put the ECG on, that's when you know, is it clockwise versus counterclockwise flow through the bundle of Kent? Okay. Does it matter to us? No. Or does it matter to the patient? No. You're going to give them the drug and send them on their way, right? But for our understanding of how these, pathologies work, that's all. That's how they present.